Thank you for the opportunity to present a lecture on echocardiographic evaluation of diastolic function, one of the most complex topics. My name is Partho Sengupta, um, and I'm delighted to be doing this for the second year in sequence. What we're going to do today is try to go through this topic, particularly enhancing on some general principles in cardiology for understanding diastolic dysfunction. And from there, we will go to the current 2016 guidelines, which are focused on assessment, echocardiographic assessment of diastolic dysfunction, followed by several case examples. And we may briefly discuss a special situation related to aging, which is inviting new ways to create perhaps newer guidelines in diastolic dysfunctions. And that's something that we are going to look forward in the near future. Diastolic dysfunction can be characterized as a latent or an unseen behavior of the myocardium, which cannot be measured directly by a one single variable. And as a result, it is called as a latent variable. So it's something that is not seen. For example, you can understand gravity as Newton explained motion, and you could measure motion to describe gravity, but gravity cannot be measured. So gravity is a latent variable. Same way, the myocardial dysfunction or the diastolic dysfunction is a latent variable which you cannot directly measure, but you can understand by different properties that are associated with that phenomena. So if you understand that concept, it becomes much easier to comprehend that diastolic dysfunction requires multiple parameters to be understood, because we do not have a single measure that characterizes it with precision. There are different parameters that can be used for describing diastolic dysfunction. So conceptually, the diastole has different phases. There is initial active relaxation, where the myofilaments are relaxing as they are moving away. And there are restoring forces, because the myocardial mechanics involves a twisting motion. And as the untwist of the myocardium happens, there's a recoil, just like a spring recoils back. This restoring forces also create suction, and that suction is responsible for the flow to be subsequently established across the transmitral filling patterns. Then you also have an intrinsic stiffness of the myocardium that resists an expansion. This stiffness is important for the later phase of diastole, when atrial contraction is happening and trying to expand further, and the stiffening of the ventricle or the resistance of the ventricle to expand any further is what gives rise to the late phases of pressure development inside the ventricle and the atrium. So if you understand the different phases of the cardiac cycle in diastole, where different activities are happening and different forces are operating, it's much easier to comprehend the filling pressures inside the ventricle. Initially, as the active relaxation and also the suction is happening, there is a rapid decay of the left ventricular pressure, creating LV minimum pressure. In fact, if you balloon occlude the mitral valve, this LV minimum pressure can be sub-zero, can be less than zero. In fact, when you do a transmitral balloon valvuloplasty, if you have a pigtail in the LV cavity, many times you start recording the spikes which go much below the zero. That means that there is actually an active suction that is happening. Followed by that, there is establishment of the transmitral flow, and the ventricle pressure increases in the central part, which is the diastasis, followed by, just before the active atrial contraction, there is the pre-A pressure. The pre-A pressure is usually similar are equivalent to the left atrial mean pressure. There is an equilibrium that is established. So left atrial mean pressure, pre-A pressure, and capillary wedge pressure are typically within the same equilibrium. So this becomes an important constituent of when you are trying to make a measurement that will be consistent across the entire circuit, the wedge, the left atrial pressure, and the LV pressure. If you want to see something all across the three circuits, it will be the LV pre-A pressure, which will be equivalent to the LA mean pressure and the pulmonary capillary wedge pressure. And followed by that, you have the A wave. Now, A wave is an atrial contraction. And because of the left atrial stiffness, this pressure wave is created. And typically during cardiac catheterization, you measure the LV and diastolic pressure. So the place where there's a notch that you can see, and this notch is typically corresponds to the LV and diastolic pressure. But it's very clear that the pressures can be very different depending upon where you're measuring. So LV minimum pressure, the mid diastasis pressure, pre-A pressure, and LV end diastolic pressure are not the same. LV and diastolic pressure are typically higher. It's possible that the pre-A pressure or the mean left atrial pressure or the pulmonary capillary wedge pressure, mean pressure, may be lower or maybe normal, while because the LV is stiff, you have a left atrial and diastolic, left ventricular and diastolic pressure, which is higher, reflecting a higher, stiffer myocardium. So it's not necessary that all the pressures are equally high. So this conceptual is very important when you're comparing different measurement. And in the guidelines, typically when you are assessing the ability to measure filling pressure, you want to concentrate upon the left ventricular pre-A pressure or the left atrial mean pressure or the pulmonary capillary wedge mean pressure. This slide is showing the physiology of the filling pressure gradient that is driving the transmitral flow. During the isovolumic relaxation, LV pressure falls rapidly, and when it has declined below the atrial pressure, a pressure gradient is established between the atrium and the ventricle. The ventricle starts filling as the mitral valve opens, and this gives rise to the onset of the E wave. You can see here, this is the gradient, and that's giving rise to the E wave. During the diastasis, the pressure gradient again equilibrates. And as a consequence, the flow across the mitral valve is reduced. And this is the diastasis phase where typically you do not see much flow velocity. And infrequently, this flow velocity could be higher if the pressures are still not completely equilibrated. And this can give rise to the genesis of an L wave. And this L wave signifies elevated mean left atrial pressure, even in the phase of diastasis. And finally, when the atrium contracts, there's again development of a gradient between the atrium and the ventricle, and you have the A wave that is created. Now, during each of this phenomenon, you can see here there is a gradient, pressure difference, a gradient, and the gradient driving the E wave, diastasis, and the A wave. Note that the peak of the E wave is happening when the gradient has fallen down and almost coming to zero. And why is then still there flow even after the gradient has completely become zero or is becoming negative? The reason being, you have a momentum in the flow that has been established. The blood is keeping on moving, and now it's getting decelerated because the gradient has got disappeared. So this is the deceleration that is happening because the gradient is disappeared, or is in fact the atrial gradient is transiently slightly higher than the base. So under these forces, the deceleration of the momentum of the flowing blood is happening. And this gives rise to a slight differences at the peaking of when the E wave happens and when the blood flow starts decelerating. Look, notice that the peak of the velocity is happening just after the peak of the gradient, and is only decelerated when it reaches, the gradient reaches 0 and lower. The pulmonary venous flow, which is coming into the atrium, has typically three phases, including a systolic velocity with two components, a diastolic velocity, and a reverse flow during the atrial contraction. You can see the reverse flow here. Reverse flow is here. The first component of the pulmonary venous systolic flow, S1, is usually hidden or combined with the second component, S2, except when there is a prolonged atrioventricular conduction or a prolonged LV isovolumic contraction time. The S2 is typically caused by RV pressure pulse, which pushes the blood flow forward, with which the flow is moving inwards into the atrium. And also there's a contribution that is happening from the systolic descent of the atrioventricular plane. Therefore, the magnitude of S wave is determined by combined work of RV, LV, and the LA systolic function. The pulmonary venous D velocity coincides with the transmitral E wave, and its magnitude is determined by essentially the same factors that modify the mitral E wave. In normal individuals, the pulmonary venous S is usually higher than the D. However, with advanced LV diastolic function, which is characterized by elevated mitral E velocity, there is typically elevated D velocity. So your D velocity will elevate. Therefore, the S over D ratio is usually less than 1 in patients with heart failure and elevated LV filling pressure. Now, young, healthy subjects with excellent LV relaxation may also have an S over D ratio, which could be less than 1, but this is because of a enhanced suction capability. Usually they have a taller E wave and a taller D wave because of an enhanced suction ability of the left ventricle. With increasing LV diastolic filling pressure, which leads to reduction in operative LV compliance, there is another phenomenon which becomes important, and that is the atrial reversal flow becomes more and more prominent. And this is, in fact, a very specific feature to suggest elevated filling pressure. And the duration of the atrial reversal flow, is an important metric to calculate for understanding the presence of elevated filling pressure. It is important to recognize that normal filling pressure at rest does not exclude diastolic dysfunction. You can have a patient who can have a normal filling pressure at rest. However, whenever you perform a stress test or an exercise, the filling pressure increases. Normally, in a healthy individual, as you exercise, the restoring forces, the suction, the uncoiling, untwisting becomes more vigorous. And this allows for rapid transport and transit of transmitral flow without causing an elevated filling pressure. So there's a unique physiology that happens where, despite the shortening of diastole, there is enhanced suction that is created, which increases the E wave velocity and causes enhanced transmitral flow transport without causing any elevation of left atrial filling pressure. However, in patients with diastolic dysfunction, you would have lack of this enhancement of untwisting and restoring forces. And a stiffer ventricle also resists a recoil or a relaxation. And as a result of those reasons, as the cardiac output is increasing, transport can happen only if the left atrial pressure increases. So the left atrial pressure then rises up, forced to rise because of the milieu of diastolic dysfunction. So stress test or exercise leads to um, a situation where you can have a filling pressure which is normal at rest. However, the filling pressure only increases whenever the patient exercises. And therefore, stress test is a very good metric to uncover the presence of diastolic dysfunction, particularly in patients with dyspnea of unknown origin. Thus, in a way, you could characterize patients who develop diastolic dysfunction can have a preclinical phase with risk factors where there is underlying milieu of dysfunction that develops, and then they become symptomatic, but only they may be symptomatic with exertion. So the resting echo may be normal, and exercise is needed for uncovering the presence of diastolic dysfunction, and exercise causes an elevation of left atrial filling pressure, and therefore exercise stress test could be useful in these situations. And finally, there are patients who have overt heart failure where features of elevated filling pressures are present even at rest. So this may happen across the continuum, and exercise can be used as a potential mechanism or method to uncover the presence of underlying diastolic dysfunction and elevated filling pressure, particularly with exertion. Another concept that is very important to keep in mind that the terms diastolic dysfunction, diastolic heart failure, and heart failure preserved ejection fraction are not the same and may not be synonymous. They are often used interchangeably but may not be synonymous. Diastolic dysfunction means that there is a milieu of an abnormal relaxation accompanied with other features that suggest that there is increased stiffening of the ventricle or altered relaxation forces in the ventricle. But the left atrial pressure may not be elevated. Filling pressures may not be higher at rest, and exercise or exertion may be needed for creating the features that are associated with elevated filling pressures. Diastolic heart failure, on the other hand, means that typically the patients are presenting with a milieu that suggests elevated filling pressure, and you can see the features of diastolic dysfunction as identified using echocardiography or invasive cardiac catheterization studies. Now, there are other patients who have completely preserved ejection fraction and who have features, clinical features of heart failure, and some of them may not have echocardiographic criteria to suggest diastolic dysfunction. Now, they may have predominantly an extra cardiac element of heart failure that leads to heart failure in form of endothelial dysfunction, inflammation, poor skeletal muscle performance, and so on and so forth. So there are phenotypes where there are extra cardiac features which may be more profound and lead to elevated filling pressure, but you may not have the patients having all the features to suggest diastolic heart failure. So these concepts currently are not very coherently described in the literature, and different phenotypes are described. But it is important to understand that heart failure with preserved ejection fraction, many patients may not have all the criteria to suggesting presence of diastolic dysfunction, versus some people have more profound features that suggest cardiac factors are involved as a mechanism of heart failure preserved ejection fraction. Another concept that is very interesting to see and understand is the continuum of cardiac mechanics as it relates to the phenotypes of heart failure preserved ejection fraction, heart failure reduced ejection fraction. There is data to suggest that the LV mechanics start deteriorating in patients who have heart failure with preserved ejection fraction. So your longitudinal strain starts going down right away. It's the most susceptible feature of LV mechanics. And there is compensatory normalization, or in fact, the circumferential mechanics may be completely preserved in the initial phases. And once they both start deteriorating down, both longitudinal and circumferential mechanics, as they start going down, the LV starts dilating and going into the phase of heart failure with reduced ejection fraction. So this is another concept or a theory that is supported with data in the literature, and is also currently existing, and also calls in for understanding the mechanical performance of the left ventricle as it relates to ejection fraction and to the syndrome of heart failure, preserved ejection fraction, and heart failure, reduced ejection fraction. In 2016, the American Society of Echo and ASE together came to create a new diastolic function guideline document. The primary goal of the 2016 guidelines was to develop an approach that would simplify and increase the utilization of echocardiographic variables for defining diastolic dysfunction in the daily clinical practice, helping towards the standardization and step towards simplification. The document stresses on quality and consistency of information, particularly between two or more indices of diastolic dysfunction that have to be relied upon during the interpretation. And it also clearly states that systolic and diastolic dysfunction are closely connected phenotypes. To a great extent, a simplification of the schematics, proposed schematics, happen. There are further work currently going on for improving the classification of diastolic dysfunction. And in the very near future, there is a newer document that is expected that will be revising some of these foundational concepts that were presented in the 2016 guideline document. However, for this particular session, and particularly related to the echo boards for this year, I'm going to relate to the findings or the features that were described in the 2016 guidelines. The first step is trying to understand if a patient has diastolic dysfunction. If any of these features are present, then you don't question if diastolic dysfunction is present or not. You assume that since there is an abnormality that is there, diastolic dysfunction is likely to be present. And you go to the second step directly. What is the grade of diastolic dysfunction? What are these features? These are if the patient has a known cardiovascular disease like coronary artery disease, has a known story of pathologic left ventricular hypertrophy, hypertensive CV heart disease, LV systolic dysfunction as noted by reduced ejection fraction less than 50%, established clinical diagnosis of heart failure, particularly heart failure preserved ejection fraction, reduced LV global longitudinal strain, reduction of mitral annular S prime velocity or mitral annular reduced mitral annular plane systolic excursion, or specific Doppler signs that are usually suggestive of presence of diastolic dysfunction, like prominent atrial reversal wave in the pulmonary wave, presence of L wave, so on and so forth. If any of these are present, then you know that the patient has diastolic dysfunction, and you go to the second step directly, and that is, what is the grade of diastolic dysfunction? On the other hand, if none of these features are present, then you're asking a question, is diastolic dysfunction present or not? Then you go towards these features, these four features. And these features are mitral annular velocity E prime, taken from the septal and the lateral corner, left atrial volume, tricuspid regurgitation velocity, and the ratio of transmitral flow velocity E over E prime, mean E prime. You look at these four features and try to run through a schematics to see how many of these are abnormal. Let's go towards these key diastolic parameters. First, try to understand how best they should be acquired in clinical practice. The transmitral E and A velocities are usually acquired in apical four-chamber view using a color flow mapping for optimal alignment with blood flow. The pulse wave Doppler sample volume should be 1 to 3 millimeters between the mitral leaflet tips, optimizing the filter and the gain settings. And then you measure the peak modal velocity in early diastole at the leading edge of the spectral waveform. Now, what are the limitations? Limitations are related usually to fusion at higher heart rates. Sometimes E and A waves are fused together, and in that situation, it may be necessary for measuring it more carefully, and sometimes the A wave velocity might need to be not measured, particularly if the E and the A waves are completely fused together. And these parameters also alter with age. It's also important to understand that transmitral flow velocities can change in their appearance based upon where they are sampled from. If you have the position into the left atrial side versus if you are having the position more towards the ventricle side, and you're not at the tips of the mitral leaflet, you can get feature that may look as if there's a dysfunction. You may get lower than the A wave. Look at this A and B, which are more towards the LA cavity. And if you move away into the ventricle, the E becomes dominant. And this may give you some misgivings with regards to an early impression that there is presence of some form of abnormality. So it's very important that it's acquired in the right way. Then you go towards the E prime, which is usually taken in the apical four-chamber way view, and you take the pulse wave Doppler sample volume at the lateral and the septal basal region. It's very important. I see this many times. The region of interest can move into the atrium or be submitral plane, and that can lead to different numbers. Good wall filter setting and optimal spectral waveforms so that they are crisp and well displayed. There's lack of feathering are important. And the issues that arise with its measurement are typically in patients where there may be less reliance on its measurement. And those are presence of mitral annular calcification, or if there is a prosthetic surgical ring or prosthetic material, pericardial disease, where there may be more restrained movement of the annulus. In this situation, there may be some challenges to getting the exact value of E prime. The advantage of E prime is it's highly reproducible. And E prime has become very commonly practiced and is very reliable in clinical practice. From E prime and the E, you get this key parameter that is the E by E prime. And typically, E by E prime has a relationship with mean left atrial pressure. Limitations are it may be not reliable in patients with mitral annular calcification, and sometimes in certain phenotypes, particularly heart failure with preserved ejection fraction, there's not a good correlation between left atrial mean pressure and the E by E prime pressure. And some of these challenges and also certain conditions like hypertrophic cardiomyopathy, where there may be reduced correlation, has been found in the literature. Left atrial volume is acquired in apical four-chamber and two-chamber views, and you use the area length method. And it's important that this is measured carefully. And perhaps the reproducibility of left atrial volume calculation is lower than some of the other diastolic dysfunction parameters. And foreshortening is frequently a problem that leads to erroneous calculation of left atrial volume. which is indexed to the body surface area. And some of these limitations should be kept into consideration, particularly when you're evaluating the images. And finally, the peak TR velocity is you need to do multiple views, at least four chamber views, or the parasternal view with the inflow view to try to get the highest TR velocity jet. And the TR velocity, peak TR velocity, is usually elevated in patients who have elevated filling pressure when the mean PA pressure is going up. However, there is a confounder, and that is people can have other reasons for pulmonary hypertension, and lung disease can cause pulmonary hypertension, may not be related to diastolic dysfunction, and that can also lead to elevated filling pressure. Particularly elderly individual can have both diastolic dysfunction and lung disease, and this concomitant information therefore may be uh, many times confounded. And for these reasons, the diastolic dysfunction guidelines stressed upon the consistency of information. So they requested that at least they be three or more of these variables be abnormal to call it as diastolic dysfunction. If there is only one or none of these parameters abnormal, then it's a normal diastolic function. If there are two positive and two are negative, then it's an indeterminate situation. If there is a situation where you have TR velocity, which is not obtainable, so you have only three parameters, and you have two of them which are positive, then you may have to look for another feature. For you may have to look for pulmonary venous flow signal to get another feature so as to jump into this category of three or four being positive. This is a frequent finding that we see in clinical practice, that the TR velocity is not obtainable, and having just two features to be present, then in that situation requires there be some additional features like pulmonary venous flow, or sometimes we go in for global longitudinal strain to be seen, and if we want to see if there is any abnormality that can be picked up, to provide more consistency that look, this patient seems to be having diastolic dysfunction. If that's not the case, and if you just have only two abnormality, then this is an indeterminate. Many times in this situation, we also request that either additional testing be performed, particularly if you're suspicious that the shortness of breath may be still related to diastolic dysfunction. You may want to do an exercise stress testing to see if some of these parameters that are measurable, they start uh, um, becoming abnormal. And more frequently, we then ask also to do maybe an agitated saline to get, if you can get some faint estimation of the TR velocity, particularly if you're going to do an exercise stress test. And many times you may be able to get an estimate of the uh, TR peak velocity using some of these additional measures like saline injection or trying to get a whiff of TR velocity at peak exertion. So the consistency of information is important, and not relying on weak data set is very important. And do not be afraid to call it an indeterminate or asking for more help, which will be a right thing to do, particularly if a clinical situation is still ambiguous. Let's see some examples. So this is a 59-year-old patient with systemic hypertension, palpitations, and shortness of breath. How would you classify the diastolic dysfunction? Normal, diastolic dysfunction, indeterminate. Ejection fraction is 60%. The E wave is measured as 0.58. Lateral E prime is 9 centimeters per second. Septal E prime is 7 centimeters per second. And TR velocity is 2.2 meters per second. LA volume index is measured as 22. So you can see here, in this particular situation, you have only one abnormality, and that is the lateral E prime velocity is reduced. So this will be a patient whom you will call as normal diastolic function. Another example, this is a 62-year-old female with hypertension, type 2 diabetes mellitus, and Reicher class 2. Ejection fraction is 60%. No, there is no LV hypertrophy. E wave is measured as 0.71, A wave is 0.96, E by A is 0.75, LA volume is increased 37 ml per meter square. Lateral E prime is 7 centimeters per second, and the septal is 6 centimeters per second. That's a mistyping there, typo there. It's 6 centimeters per second. You can see here the TR velocity is 2.7. So this patient has two sets of abnormality, elevated LA volume index and a reduced lateral E prime velocity and a reduced septal E prime velocity. Only two are positive. So this patient would be written as indeterminate, and you would require to look for other features to support diastolic dysfunction or even perform an exercise stress test if the question is not yet solved. Let's examine another case. So here is a patient. You can see the left ventricle. You can see the transmitral filling pressure E by A ratio of 0.9, and average E prime is 12, LA volume is 30 ml per meter square. And the question we're asking, is this patient have diastolic dysfunction? The answer is straight yes. Why? Because look at the wall motion abnormality. Look at the LV systolic function is abnormal, is reduced. You can visually see the ejection fraction is reduced. Once you have presence of LV systolic dysfunction, wall motion abnormalities, the question is not whether diastolic dysfunction is present or not. The question is, what is the grade of diastolic dysfunction? Because diastolic dysfunction is present since the patient already has an underlying myocardial disease or myocardial dysfunction. So we go directly to the step 2 after saying that this patient has diastolic dysfunction. Now, what's the grade of diastolic dysfunction? Now, to look into the grading of diastolic dysfunction, you have this complex pathway schematics. But if you look at the schematic overall, it looks complicated, but it's pretty simple in terms of how it follows. And let me simplify it here for you. Well, if you just look into the transmitral flow velocity, and if you look into it being reduced less than 0.8 or more than 2, then you know that you're going towards grade 1 or grade 3. Majority of the times it will be normal if it is lower than 0.8. And if it's elevated more than 2, then it's a grade 3. In fact, this is very simple. If the transmitral filling pattern in a patient who's got systolic dysfunction, and you're trying to grade the diastolic dysfunction, and if the E wave is E by A ratio is more than 2, the job is done. This is elevated filling pressure, it's grade 3 diastolic dysfunction. And if it is transmitral filling pressure, in majority of the circumstances, if the ratio is less than 0.8, majority of the time, it will be grade 1, except on certain situations. If this is accompanied with a normal E by E prime ratio, a normal TR velocity, a normal LA volume, then you know that this patient doesn't have elevated filling pressure and this patient has grade 1 diastolic dysfunction. If 2 or more of these are abnormal, even if the E by A ratio is 0.8, then it could be an elevated filling pressure despite the E by A ratio being 0.8, and you go into the grade 2. The grade 2 being a pseudo-normal filling pattern majority of the times, and there being consistency of elevated filling pressure as seen by elevated E by E prime ratio, elevated TR velocity, and increased LA volume index. So you can see here the grade 2 dysfunction typically is very clearly related to pseudo-normal filling pattern, but sometimes you can have a patient who may look like transmatter flow is looking like grade 1, but there are parameters that are abnormal more than 2, then they can be grade 2. So this is the overall viewing of grading of diastolic dysfunction. And let's see a few examples to show. So uh, if you have a transmatter filling pattern, and uh, that is showing completely normal. If two or more are negative, then it's grade 1 diastolic dysfunction. And if it is, on the other hand, uh, there are two or more of the criteria are abnormal, then it could be elevated filling pressure. So let's see an example here. So you have here a patient, looks like has a structural heart disease. Looks like the LV is got wall motion abnormalities in the inferior wall. Uh, the left atrium looks already dilated. You have E by A ratio is 0.54, so it looks like it's less than zero point 0.8. E by E prime is elevated. LA volume is elevated. TR velocities are normal. So you have a situation here where the E by A ratio looks normal or less than zero point 0.8, yet there are two features which are abnormal, and that is E by E prime is increased and LA volume is increased. So you have this situation. So uh, you can have uh, a situation where the E by E prime is uh, E by you have a situation where the E by A ratio is less than zero point 0.8. However, there are two features which are showing elevated filling pressure. So E by E prime is increased more than 14, and TR velocity is more than, uh, LA volume is more than 34 ml per meter square in that particular example. So it suggests elevated left atrial pressure. So that will be called as grade 2 diastolic dysfunction according to the guideline pathways. Now, this is a 71-year-old patient with heart failure, and the patient has an ejection fraction of 55%. LA volume is increased. You can see the chest x-ray. So this clinical presentation is heart failure. The chest x-ray is showing pulmonary congestion, pulmonary edema. Uh, TR velocity is 3 meters per second. And when you look into the transmitral flow pattern, you have this positive wave in diastole, mid diastasis. So you have the E wave, and you have the A wave, and then you have this diastasis wave, which is also called as L wave. This is a classic feature of triphasic filling pattern seen in patients with heart failure, where, as I previously described, you have an elevated left atrial pressure. And even during the phase of diastasis, the LA pressures are still high. So there's a continuous wave that is going on even during the phase of diastasis. And this is a sign of elevated filling pressure. Typically, it has to be more than about reaching up to about zero point 0.4 meters per second, and qualifies as elevated filling pressure in mid-diastole or L wave, and is a specific sign for elevated filling pressure. So the criteria described by the 2016 guidelines has been validated in several trials, and there has been effort that shows that these variables can be measured, and there is robust sensitivity and specificity. In fact, the specificity is higher, And there's been some criticism in the literature still on the lack of age or sex defined uh, values for the different variables, and also that there may be some degree of loss of sensitivity because some of the variables may be more gated towards specificity. And that is likely to be resolved by the next round of revisions, and a new guideline is likely expected in the very near future. Some of the other limitations of the 2016 guidelines include the characterization of indeterminate diastolic dysfunction. The way I look at the stage indeterminate is not to stop at that point, but to make an effort to get more variables to see if we can qualify the patient either ways, normal or dysfunctional, or to ask for exercise testing where you really do not have the answer. You have lack of measurement of TR velocity, and age-specific cutoff values may not be have not been applied, and this is something going to be needed in the near future. And there is a higher specificity, and that leads to a lower calculated prevalence of diastolic dysfunction. There are also certain challenging situations like atrial fibrillation, significant mitral valve disease related to mitral annular calcification, presence of mitral regurgitation, or cardiomyopathies like hypertrophic cardiomyopathy, where the guidelines go in and provide some criteria that may help in deciding the presence of diastolic dysfunction and grading diastolic dysfunction. However, they continue to stay fairly challenging. And also, diastolic dysfunction may be difficult to define in presence of rhythm abnormalities like left bundle branch block and presence of ventricular paced rhythm, and in patients who have LVADs. So these are certain areas where still there is lack of certainty on how best we can approach the situation. As I stressed several times in my presentation, that whenever you are not sure in a given situation, instead of calling it indeterminate, or instead of uh, relying on stopping at that phase, you may ask for more variables to see, look for more variables if there are any abnormal variables, or you may call in for the need for stress testing, particularly if the patient is symptomatic and you're concerned that you're missing a diastolic dysfunction, then diastolic stress testing could be useful. It's not typically performed. It's not typically performed routinely in clinical practice, but it's been more and more advocated. And the guidelines call in for measuring for E by E prime ratio, and looking for its elevation with exercise, looking for trying to obtain the TR velocity. Sometimes you can use agitated saline to bring that signal. It's sometimes not difficult to obtain even on exercise. And even despite all this results, maybe the test may stay indeterminate, and you may ask for an invasive catheter-based assessment with exercise in those situations. There are several new other methods or variables that have been introduced, particularly global longitudinal strain. Left atrial strain is coming very quickly as a very important marker of diastolic dysfunction. In the very near future, you're going to see more and more incorporation of left atrial strain into clinical guideline documents. There are also other variables like LV untwisting and LV untwisting rates, strain rates, that are not completely standardized. And there is more and more work that is happening in the field of data mining techniques, using machine learning techniques, which there is increasing reports that some of these techniques may allow us to cluster the information more readily for busy clinical practice. And machine learning techniques may be one of the ways we can use assessment of diastolic dysfunction, in which you can ingest multiple variables and get a prediction of presence or absence of diastolic dysfunction. And this is something to look forward to in the near future. It is important to understand the effects of aging on some of the diastolic dysfunction. It's important to know that aging may not affect the left atrial pressure. So the left atrial pressure typically does not increase. However, the left atrial compliance, chamber stiffness, and the relaxation rate in early diastole changes with age. So you can see here different studies that are showing how the E prime reduces with age. And therefore, you can understand that there could be a need for using more age-specific cutoff for defining the presence or absence of diastolic dysfunction. A threshold, for example, of 7 or 10 on or an average from them may be normal in elderly people. So in elderly people, you might need even lower threshold to call for presence of a relaxation abnormality. Similarly, it has been shown that the E by E prime does increase to some extent with age. However, typically does not reach the threshold of 14 that has been defined in the guidelines. So if you see in an elderly individual an E by E prime ratio of more than 14, then that typically indicates presence of elevated filling pressure. So it could still be relied upon as a marker of elevated filling pressure. The E by A ratio changes with the E velocity falling down. And therefore, in an elderly individual, you can see a transmatter flow pattern. It's not uncommon many times to see the E by A ratio could be approaching the zero point 0.8 parameter that is defined in the diastolic dysfunction. And same way, because of concomitant lung disease, many times you see the right ventricular systolic pressure can go up. So the TR velocity also may go up. So there is some degree of caution that is needed for applying the diastolic dysfunction criteria. In fact, there is a recent study from the World Alliance Society of Echocardiography Normal Values, where they looked into the prevalence, age-related prevalence of the diastolic dysfunction parameters. And what they found was as as they approached elderly individual in this data set, more and more of these normal individuals were called out for presence of diastolic dysfunction, or at least as based upon the 2016 EACVI guidelines document. And in fact, it was suggested that perhaps we need to think about some form of nomograms or changing the nomograms values for some of the parameters, particularly the E prime and the left atrial volume index. The left atrial volume index was also seen to be larger in elderly individual. So thus to conclude, LV diastolic dysfunction is a latent behavior of the myocardium that cannot be measured directly with single parameter and requires multiple parameters to be assessed. It should be assessed routinely and presented routinely in clinical reports. Particularly, it's relevant for management of patients who come in with symptoms of dyspnea. And since there is more and more importance to the filling pressure, because that's the one factor that you can treat or manage in patients with heart failure, the filling pressure, the guidelines stress upon variables that will look into the presence of elevated filling pressure or absence of elevated filling pressure. The elevated filling pressure and the grading of the LV diastolic dysfunction should be commented upon, therefore. In patient with reduced LV ejection fraction, transmitral inflow pattern is very good index of looking into the grading of diastolic dysfunction. And using a multiparametric approach, we can come at fairly accurate assessment of left atrial filling pressure, particularly in patients who have myocardial disease or or abnormal LV function. Diastolic stress test is emphasized in the guidelines, particularly for patients who are continue to have dyspnea of unknown origin and where you do not know whether it's coming from the myocardium. And if you cannot get the answer on exercise echo stress testing, you may also need to look into exercise cardiac catheterization to get the answer. And further iteration of guidelines will be taking in new cutoff values and for E prime and LA volume index probably, and also maybe incorporation of robust parameters like left atrial strain, and using new machine learning approach, which could help us simplifying the processes for arriving at the diagnosis. Thank you very much.